Welcome to a clinical overview of pneumocystis jirovecii pneumonia, or PJP, in the non-HIV immunocompromised host. Radiologically, look for hallmark bilateral ground glass opacities, reticular patterns, and interlobular septal thickening on high-resolution CT of chest. In non-HIV patients, PJP is a different beast. It presents acutely over days rather than weeks and carries a much higher mortality rate of up to 60%. While fungal burden is lower, the neutrophilic inflammatory response is far more intense, often leading to rapid respiratory failure. Risk stratification is critical. Prophylaxis is mandatory for Tier 1 high-risk patients, including those with acute leukemia, allogeneic transplant, or those on alemtuzumab and PI3K inhibitors. We also consider prophylaxis for Tier 2 patients, such as those receiving CAR-T therapy or bispecific antibody treatment. A key takeaway is the corticosteroid rule. Any patient on 20 milligrams or more of prednisone equivalent for at least 4 weeks requires mandatory prophylaxis. This is especially vital for patients with brain tumors, glioblastoma, or high-dose regimens for autoimmune diseases. When clinical suspicion arises due to hypoxia, cough, or fever, move quickly to an HRCT, as a normal X-ray does not rule out PJP. Bronchoalveolar lavage with PCR is the gold standard, as traditional silver stains often miss the low fungal burden found in non-HIV cases. The shield against PJP is trimethoprim sulfamethoxazole, which provides a 91% risk reduction. Preferred adult dosing is 1 single-strength tablet daily, continued throughout the duration of immunosuppression. If trimethoprim sulfamethoxazole is contraindicated due to allergy or myelosuppression, second-line options include atovaquone, dapsone, or aerosolized pentamidine. Note that atovaquone is preferred in stem cell transplant because it also provides coverage against toxoplasma. For active infection, start high-dose trimethoprim sulfamethoxazole at 15 to 20 milligrams per kilogram per day for 21 days. If the patient is hypoxic, add corticosteroids immediately to prevent an inflammatory flare. Patience is key during treatment. Inflammatory worsening is common between days 3 and 5, so do not declare failure until after day 8. If salvage therapy is needed, the preferred regimen is primaquine plus clindamycin. In summary, suspect PJP in any hypoxic patient with ground glass opacities, prophylax high-risk and steroid-dependent patients, and treat aggressively with high-dose trimethoprim sulfamethoxazole. Finally, remember that PJP requires droplet precautions to prevent patient-to-patient transmission. Hope you enjoyed this session. Happy learning!